Thomas Baldrick here at ASH 2014 in San Francisco, joined now by Dr. Sam Schulman from McMaster University in Ontario. Thanks for stopping by, sir. So
Welcome.
You've been a busy guy. You got 3 abstracts here. Let's talk about this one analysis of 2 randomized studies with over 5,000 patients involved.
So we performed these 2 pivotal studies to test the new blood thinner Dabigatran versus Warfarin in patients with acute venous thromboembolism. Those were twin studies, and therefore we could pool the results, and we got over 5,000 patients. And we showed in the main studies that Dabigatran was non-inferior, was similar in effect to Warfarin in preventing recurrent venous thromboembolism and reduced the risk of bleeding. But after we presented that as articles and at oral presentations, there were questions, but how about patients with cancer? How about patients with renal impairment? How about the elderly patients? And that led to a number of subgroup analyses.
What are some of the key pieces of data that you have to present?
The key piece of data is that we have a drug that we can give instead of warfarin without monitoring, without having to tell the patient to go for INR every 2 weeks average. They don't have to worry about eating salads or spinach or broccoli. They can eat as much as they want. Hardly any drugs interact with Dabigatran as opposed to over 100 drugs that interact with warfarin. And it is with a lower risk of bleeding, particularly intracranial bleeding, which is the most feared bleeding on anticoagulants. It was shown with atrial fibrillation indication that the new anticoagulants reduce the risk of bleeding. It was also shown in a meta-analysis of the studies with all the new anticoagulants in venous thromboembolism that the risk of intracranial bleeding is reduced by half compared to warfarin.
Dr. Schulman, you had some interesting work to do around the differences between EMA and the FDA, Canada and the US. Can you touch on that?
Interestingly enough, we tested only 1 dose of Dabigatran, 150 milligram twice daily, and FDA approved that drug for all the patients, even those with moderate renal impairment or patients with, who are elderly. But EMA and Health Canada said, no, we want to recommend or at least suggest that patients who are elderly or with moderate renal impairment should have a reduced dose of 110 milligram twice daily. This was a bit of a concern to me because we never tested 110 milligram on this indication. It was tested in atrial fibrillation, where you have a much smaller clot in the appendage of the atrial chamber. But when you have an acute deep vein thrombosis, which can include the entire leg or massive pulmonary embolism, you don't know if the 110 milligram really will work. And we did not have a feeling that the 150 milligram caused increased risk of bleeding, because overall the data was extremely positive that we reduced the risk of bleeding. So why should we reduce the dose and take the risk that the elderly have recurrent events that could be potentially fatal?
Very good.
So then we did this subgroup analysis that we present here at ASH, and we can show that in the elderly, and especially those with moderate renal failure, the drug works extremely well. There are no recurrences on Dabigatran. There are some on warfarin, no recurrences at all on Dabigatran. Is that at the cost of increased risk of bleeding? No, the risk of bleeding is the same as with warfarin, but not higher than warfarin. We don't tell patients to take less warfarin if they're elderly or have renal impairments, so why should we tell them to take less Dabigatran then? We still want to protect them against recurrent venous thromboembolism.
Very good. To be continued, correct?
Thank you.
Thanks for stopping by. We look forward to seeing you again.
You're welcome.